I just want to quickly start by introducing our team for the day. With us are Kamal Abulebda and Samar Abu-Sultaneh, and then in the back in the purple is Zach Berrens. All three of them are pediatric intensivists here with Riley Hospital for Children right in Indianapolis. And then Michele Kirby is one of our nurse flight specialists. She's a peds neo specialist with Lifeline, which is one of our aeromedical teams for Indiana and the one affiliated with Indiana University Health. And then Brian Phillips, who's seated back there, and myself, Elizabeth Weistein, are emergency physicians at Riley Hospital for Children in the emergency department there within the Division of Pediatric Emergency Medicine. Now, all of us work in the Mecca. We work in the quaternary referral site for pediatrics for the state of Indiana. However, all of us also work in less resourced community settings. So our intensivists also spend time in smaller community PICUs where they have fewer resources in the hospital. Brian actually spends half of his clinical time in a very busy community ED with a large pediatric volume and 3 inpatient pediatric beds. I spend some of my clinical time at our county trauma center where we have no inpatient pediatric beds with the exception of a NICU. So we've used that lens to our advantage during some of our simulation outreach, and I bring it up at the beginning only because you may not have those opportunities to have a different lens, but figuring out a lens that works and resonates well with your outreach communities is really important, and it's been really important for us. A little thank you before we get started to the folks that have funded our efforts. That would include Indiana University Health Values Fund and then an interdepartmental grant through the Department of Pediatrics at Indiana University School of Medicine. Just a quick show of hands before we really dive in. How many of you identify as categorical emergency medicine? And how many are subspecialty trained in PEDS-EM or dual trained in emergency medicine and pediatrics? And then how many of you are doing other either resourced or maybe in a different clinical venue? So a handful, it's a kind of wide spectrum of folks here in the emergency. And how many of you are actually doing simulation or outreach stuff right now? So 1, 2, 1.5, we'll say. And how many of you are actually looking at implementing some outreach in your programs? Great, so a good cross cut, I think, of the community here. What we would like to do over the next 40 minutes or so is really provide you with some tools and resources to begin to develop simulation and outreach programs in your shop or to find alternative opportunities if you've already begun to do outreach where you are. At the same time, we'll talk to you in more detail about one of our programs, and within that program, we'll talk a little bit about Pediatric Readiness as our program really used that as an anchor for our outreach. And then lastly, we'll end with some breakout sessions to look more at the nuts and bolts of actually doing your workshop, so looking at coordinating outreach and looking at the actual equipment that you need to have with you, and then also talking about funding opportunities, leadership buy-in, and scholarship opportunities if you develop these programs. So why are we talking about this at all today? Well, it turns out pediatric emergency care is a big deal in the U.S. Institute of Medicine told us in 2006 that we are woefully underprepared to take care of kids. And while many of us sit here working in institutions that have a lot of resources to take care of children, the fact of the matter is that more than 80% of kids in the U.S. are seen in general EDs, which is great, but most of those EDs see fewer than 15 kids a day, and very rarely are those kids really, really sick. And so the fewer kids you see, the less ill they are, the further you are from resources for cutting-edge evidence-based medicine or guidelines or protocols or subspecialty support, the harder it is to be ready on a daily basis to take care of kids well. How many of you have heard of the Pediatric Readiness Project? So about 3. So the Pediatric Readiness Project was launched in 2013 as a joint effort to try and benchmark our preparedness to take care of kids every day in emergency departments throughout the country. Over 5,000 emergency departments were sent pretty thorough surveys to look at their processes and resources to take care of kids. 82% of them actually completed those surveys, and that data has been used to help us understand where we are as a country and where we need to move forward. This effort has been launched in cooperation between the Emergency Nurses Association, the American College of Emergency Physicians, the AAP, and ACEP, with a goal of ensuring that every child who's ill and injured in the U.S. has timely access to appropriate care. Here in Indiana, we utilized this score to really anchor our outreach efforts. So the score itself is a weighted score, 0 to 100. So facilities would fill out the survey, they would get a score back that they called their weighted pediatric readiness score. Again, 0 to 100 based on their performance in 6 different domains. Specifically, they looked at things like administration, quality improvement, policies, procedures, equipment and supplies, based on a policy statement by the AAP and ASAP for guidelines for care for kids in emergency departments. Once they had that score, they were actually given some gap analysis and suggestions for improvement, but that's really hard to do on your own. Nationally, when we look at the median score is 69 out of 100, and you can see that that number changes substantially depending on the volume of patients that you take care of. So higher volume facilities were able to have higher scores. Here in Indiana, our score was 67, so just a little bit lower than the median, but enough to make this little fella grumpy. So we utilized this as a starting point for our outreach and tied actual readiness assessments and readiness improvement efforts to in situ simulation programs in hospitals throughout the state, which Kamal will tell you a little bit about in detail.
All right, so I'm going to try to link what I'm going to talk about to what Elizabeth talked about already, what I'm going to talk about simulation in the ED settings. And I'm going to start with a couple of pictures of actual simulation we have done actually around the state of Indiana with our team members. And what did we do exactly? Actually, we started this around 2.5 years ago. And we came up with a kind of funky name to our team. Worth mentioning, our team have 3 foreigners out of 5. So we won by making our team called PCOM. And that PCOM actually includes Pediatric Community Outreach Mobile Education. And I will say exactly why did we choose this name. So pediatrics obviously came from us being the academic pediatric medical center in the state. And community mainly really on need assessment from a lot of community emergency departments around us that refer to us all the time, and almost all these EDs are community-based, general EDs, non-academic center, which we know exactly what kind of struggles or certain gaps in skills resources they may have based on the PRS survey we had previously. Outreach, and I think this was probably the most cutting-edge component of our program, because historically those EDs, community EDs, always reached out to us by referring these patients, by calling us about follow-up of this patient or that patient. We have a DKA patient, we want to know what happened to him. We have a status patient, we want to know what ended up happening. So we kind of reversed that process, and we said we're not going to sit here and just wait for them to reach us after the patient is being managed or mismanaged. We're going to reach out to them, and we put the outreach in the middle because I think it's really an integral component of our team. And mobile, obviously, because we are reaching out to them, so we can't be in our offices just sitting and complaining like we did before. And education actually was the main platform of our intervention, using simulation as an educational intervention tool for our program. So we end up having a PCOM team. No matter how we want to pronounce it, we call it PCOM. And this is actually our team, initial team members that we have 4 intensivists and 3 critical care lifeline transport team members. And we have our folks from the emergency division as well at Riley and IU Health, who were a very important component of our team. And this actually was our roadmap at the beginning when we started doing our work. The methodology we have in mind was all based on ongoing communication at any certain point during this process. So we start by having a need assessment in these EDs. And even though we know a little bit about what these EDs need from other reports that have been happening, either through retrospective studies or surveys, we decided to go there on-site, in situ, and do our own assessment, because we think this is probably going to be the most reliable and accurate way of having an accurate need assessment of these EDs. So as you notice, we start with the initial on-site assessment where we assess the pediatric readiness scores using on-site resources. So we all know Marianne Gashel did the survey for the last 10, 12 years in 2003, 2015. All these surveys were based on just web-based surveys of PRS. We did that a little bit different by going in there, assessing the resources using on-site verification. And based on these assessment, we drafted our reports out, or what we call them assessment reports, which basically has the 6 domain of the PRS, the pediatric readiness scores, with each domain have their own deficits and gaps with a simple intervention plan for that specific area. And that was obviously supported with education resources and sharing all the expertise we have at the academic center. Following that, we did the simulation visit where we went there, and what we call it the intervention simulation visit, where we go there, introduce the whole team, and we further enhance the platform of intervention by performing on-site in situ simulation. So not only we did the initial assessment that we use as initial survey of these ED's readiness for taking care of sick children, we went there furthermore after we drafted those assessment report and do simulation in situ to further link the PRS component, which is tell you what is the structure or process of care, with the simulation part, which tell us more about the actual performance of team providers in these ED that we already have their PRS assessment. And following all this intervention plan, we did a follow-up assessment of their PRS to see between the initial report and the follow-up report, following our targeted intervention, if we have any improvement in the scores in these 10 ED that we have targeted at the beginning. And the next slide, this is just another phases kind of slide showing us the preparation period where we got all our stuff together, our paperwork, our grants, our surveys, and our team assembling. And then we start with the initial assessment visit where we did the PRS, then the intervention. Following that, we did the follow-up assessment visit, and eventually the data collection and the dissemination for all the 10 to 12 sites we did in the first phase of our work. And we came with the pediatric readiness score in Indiana that was based on our interventions. So we have PRS in-person, on-site measurement in 10 ED sites, community or general ED sites, or non-children ED site, however you want to call it, in Indiana. And we did initial and follow-up assessment and gap analysis, and we end up with improvement in all PRS of these EDs. This is, we'll show you part of our report, our assessment report, actually the front page of it, that we're going to show it in the stations once we finish the presentation. And this is actually, tell us more about the collaboration. It's kind of unique collaboration we did in Indiana to accomplish this improvement by having the medical center, which is the Riley Hospital for Children, linked to the Lifeline, which is our major transport team in Indiana, under the umbrella of IU Health, combined with our pediatric community outreach program. We all targeted this community EDs. And this was actually our work that we published last year in the consensus conference volume of issue of the SAEM journal. And we clearly demonstrated we have significant improvement in the pediatric readiness scores in all these EDs from a pre-intervention to post-intervention from 58 to 74. And furthermore, we have improvement in all the component of the 6 main domain of the PRS survey. So it was actually very impressive to us because we weren't expecting this result when we first started this. We were expecting some improvement, but I think in their defense, and to be fair, big part of the improvement was on their shoulder, not on us, because the engagement we had from them combined with the collaboration has definitely helped us accomplishing this improvement. And I'll let my colleague Samer talk about next slide.
Okay, so we'll talk about the components of our outreach program. So we like to divide them in four components. The first thing is the in situ simulation, then how we reach out to sites, and how we gather our equipment, then our resources. So for the in situ simulation, we like to call it point of care, meaning that we use the ED same patient room, we use their resources, and we use it as investigation tool to assess the system issues and the care process, and it's a training tool that is used to improve quality of care for simulated care and also clinical setting. So as Kamal said, instead of actually complaining about what we get from community EDs, we say that we get, wrong size tube, tube that was inserted very deep. We will go to these EDs, teach them about the current guidelines for airway management. And what we did for respiratory case is we improved actually the appropriate ET tube size, the ET tube depth, and also other equipment like the laryngoscope blade, other also equipment needed for intubation. The same thing with the DKA. 23% of our patients received IV bolus of insulin, which is not recommended by the pediatric DKA guidelines, and only 47% of them received the required hourly glucose checks. So we did the DKA case, and in the follow-up visit, we found that we had improvement of the fluid type, fluid rate, and also not using bicarb, not using insulin, and checking the required labs. So again, how we do it as in situ, we go to the EDs, we use their clinical resources, we use their equipment. Even if they don't have equipment, we point out what equipment they don't have. We use their also, people. So it's actually their team that they try to resuscitate the patient, and that allows us to detect the latent safety threats and put it in the assessment report that we'll share with the site. After each simulation, we do debriefing, and the focus is also on the safety threats, on the equipment that they have. We do some hands-on. We try to share our resources or find other resources for them. Some of them, they have used the mobile app, so we try to help them to locate resources that they can use for actual patients. The learning team is usually composed of 1 to 2 MDs, 2 to 3 RNs, and 1 RT, and 1 to 2 EMT, with social worker and pharmacist if they're available. And we think this composition is actually what is a resuscitative team will be in the ED if they have a case of respiratory failure or DKA. Usually the schedule will be announced, and they will be planning with their champion or educator before we start our simulation visit. So how we reached out to the sites, how we recruited the sites. As Kamal mentioned in the previous slides, that we have 3 of our lifeline specialists that they work with us, and they go and pick up patients from these sites, so they know the people there. We try to see which patients, which EDs we get more volume from, utilize our pre-existing relations, as I mentioned, and also talk to the medical director, the nurse educators, to the ED managers to try to recruit sites. And then also use our relationship with the local EMSC. This is the map showing our work so far. This is the center, as you can see, the Indianapolis, where's the star, but we went north and south and east and west, just trying to cover the community EDs around us. For equipment, it's very important when you move with all of the equipment, you need to fit all of the equipment needed. So we need usually 2 cars to go. We don't have a van to carry all of our stuff. Sometimes we don't have space, even we do some simulated driving with our mannequins. So make sure that you put your car seat belt when you go with this guy. Then the last thing is sharing resources. So there is open channel between us and these sites, and whatever protocols, whatever flow sheets they need, we share with them. So we shared with them some pediatric vital signs, also how to calculate fluids for pediatric patients, DKA management flow sheet based on the pediatric DKA management guidelines, and endotracheal tube also tag cards that we give it to all participants. Also, our policies and procedures and these cards are available in our website. So if they need also other stuff that they are not available there, they usually contact us and we will provide them whatever resources they need. This is our group, this is our emails. If you have any questions, let us know. We'll be happy to answer any questions about the logistics. After the stations, we can have more talks about how we initiated our program that we started about 2 or 3 years ago. So now we'll divide in 2 groups. We'll spend about 12 minutes in each station. The first station will be Station A, which is in the corner where Zach and Michele and Brian are, and we will discuss the coordination of outreach program and how to travel with equipment. And Station B, which will be in this area, we'll discuss the funding and also scholarly work. Do you have any questions before we start?